Hello, and welcome to tonight's webinar, Definitive Catheter-based Neurostimulation to Treat Dysphagia. I'm Anil Kenny, VP of Global Marketing at Phagenesis. Tonight, we have distinguished faculty from Banner University and Wake Forest here to talk about pharyngeal electrical stimulation, or PES, a novel therapy to treat patients with neurogenic dysphagia following stroke. Dr. Andrei Alexandrov, professor and chairman of the Department of Neurology at Banner University in Phoenix, Arizona, will lead tonight's presentation. Dr. Alexandrov will review the importance of treating dysphagia early in the ICU, introduce PES therapy, and highlight results from his team's early clinical experience. Katie Canosa will follow Dr. Alexandrov's presentation. Katie is a speech-language pathologist and board-certified swallowing specialist at Atrium Health Wake Forest Baptist in Winston-Salem, North Carolina. Katie will dive deep into the neurophysiology of swallowing, the mechanism of action behind PES, and review 3 patient cases where PES demonstrated positive clinical results. Dr. Brenda Towsley is a neurogeriatric clinical nurse specialist at Banner University. Brenda will close our presentation with her experience introducing PES therapy into the Banner Health system, highlighting tips and tricks for a successful enterprise implementation. We would like to thank everyone for logging in tonight from around the world. You're taking time out of your busy schedule to be with us, and we greatly appreciate it. Now, before we begin, a few housekeeping items. First, tonight's webinar is being live streamed from 3 time zones, including a local watch party in Los Angeles. Because of this setup, you may encounter some technology issues, especially during the speaker transitions. Please be patient with us. We will do our best to minimize these issues. Second, tonight's presentation will last about 40 to 45 minutes, with the remainder of the hour reserved for Q&A. Please submit your questions at any time during the presentation using the Zoom Q&A function. Carrie Manipenny, our global leader of clinical education, will moderate the discussion and answer your questions in real time. If we don't get to your questions, we will do our best to follow up with you offline. Lastly, this webinar is being recorded and will be available to rewatch next week. Look for a link in your inboxes and on our socials. And now, I'll hand it over to Dr. Alexandrov to begin.
Thank you, Anil. I hope you can hear me. And welcome to this first webinar broadcasted from United States about this technology that has been around Europe and the world. And one can say why Alexandrov is now entering dysphagia field, because I'm known for something else, not dysphagia. Well, I'll tell you the story. So, and thanks to our sponsors, the Phagenesis. Next slide, please. My disclosures are that I'm traveled to this particular location supported by Phagenesis. Next slide. So dysphagia is a problem. And we as stroke neurologists caring for our patients know that it can, first of all, be very common. Up to 3/4 of the patients can experience that. And they can sustain it, leading to really dissatisfaction with the quality of life. Not to mention that our neurocritical care colleagues, are dealing with this. And if dysphagia is present, they need to protect the airway. And so that leads to trachs and pegs and so forth. So all those things that can increase ICU stay. Next slide. So how did I get into this? So this is the actual story. I had my patient, a young mother who was very proud, who developed dysphagia as part of her stroke, and she refused PEG tube. And when I asked ENT to come and help her, they said there is nothing to do. She needs to be pegged. There is no other alternative. And it was 120 degrees Fahrenheit in Phoenix, and she was surviving at home, downing Jello shots. Can you imagine that? So not being able to drink water. So I thought that was unacceptable because she's going to die. And I started to kind of complain to friends that there is no treatment. And a friend of mine said, there is another friend of mine who knows about the treatment. And that's how I came about Phagenesis. It turned out they just got FDA approval just a few months before that happening. And so I decided that we need to bring this therapy to save this young mother. And I was blessed that my CEO supported it. And from the moment we placed the request for the catheter was delivered, and we were ready to go in 7 days, including training. And I'd like to thank Phagenesis for that. She underwent 6 treatments. And at the end of treatment, I asked her, what's your favorite drink? She said, Coke. Well, I didn't comment on the stroke preventive qualities of that drink, but I brought her the bottle of coldest Coke I can find in the hospital vending machine, and she drank the whole bottle without any aspiration. She's very, very happy right now. So that's my story, how I entered this field. It was the patient that needed literally to be saved from dysphagia. Next slide. So this is the time of development. Apparently, this technology has been researched for over 20 years in Europe, invented in Europe. There were multiple clinical trials that led to European approval. And interestingly, FDA also approved this as a breakthrough device based on international data. Kudos to FDA. I developed things, and I know how FDA strict is to require American data before they even consider that. So I think this is a real breakthrough that we have this technology without a phase 3 trial executed on in the United States. Also, European guidelines are all supporting that, EU, German, and UK guidelines. Next slide. So how are we approaching dysphagia right now? We have a speech-language pathologist following my presentation who will tell you more about this. But I explain to patients and to our speech-language pathologists what do we do with this, asking patients to practice with ice chips. Think about it. It's like you go to a gym to build muscle, right? What, do you come to the gym and stand there with weights and wait until your muscle grow? That's what we do with ice chips. We're waiting for them. So instead, this device actually can treat and actively make the patient exercise. And Katie is gonna show you how to do it. And then, like everything we do in stroke, we believe that the earlier you start treating, the sooner you will get the patient to the next level. And look at the outcomes in randomized clinical trials. This is at the bottom of the slide that they demonstrated in Europe. Look at the absolute percent differences. We're talking 30%, 40%. I mean, cardiologists would have died to have outcomes like that, right? The PES would have been at every gas station or cath lab, for that matter. So this is a highly effective treatment to reduce the burden of dysphagia. Next slide. So we can avoid poor clinical outcomes, we can improve quality of life, and we can decrease economic burden to the hospital and the system. Next slide. So this is our data that in part we presented already at the International Stroke Conference this year in Phoenix. We put together data from 3 institutions. I'm going to show you just what was our experience in Phoenix. So first of all, if you look at across improvement of quality of life, some improvement was experienced by all patients who received that treatment. And there were also avoidance of intubation, if intubation was imminent, avoidance of a PEG tube. I think it's a great outcome. If you are destined to walk out of the hospital or leave the hospital horizontally with a PEG tube, that's not a good outcome. So if you can swallow, if you can advance your diet, that gives you really good quality of life. Interestingly, it was seen across the spectrum of stroke severity. We had patients who were acute to subacute when we decided to start treatment, and we had patients who already were lingering in a floor, just waiting dispo and being depressed. One of them was just barely 20-some years old, completely depressed because he cannot swallow. He has some understanding, but he cannot talk. And we agreed to treatment of that particular patient, and he started to swallow. And you can see how life came back to his eyes. And he, even though he still ended up going to a nursing home, but this time he went there where he was able to start enjoying his own meal. So next slide. And here, what
a chef from Prescott Valley is on the mend.
Just a second. Yeah, thank you. So it takes a village. So, and you will hear from Brenda, our nurse leader, what it takes to bring this technology on a dime, or in terms of time, in our case, or what kind of commitment of resources you would need to make a difference. It needs to be a team effort. Yes, you need to have physician champion, but I think the best recipient of that technology is speech-language pathologists. In fact, when we brought this and they saw the very first result, they became so happy because they walk into patient's room with that device and they can actually actively treat, as opposed to, oh yeah, stick the ice chips and I'll be right back, right? Okay, so anyway, they tolerated it well. Katie is going to tell you more results. And we had particularly very interesting result if you have acute Wallenberg's. So, and I'm going to leave you with that video that's going to play, and that would be invitation after the video for Katie to join us. Thank you.
Suffering 3 strokes. A chef from Prescott Valley is on the mend after suffering 3 strokes all at the same time.
But the strangest part of this story is during all of this, he lost the ability to swallow. Fox 10's Brian Webb shows how a Valley hospital had a plan to help.
Michael John Coe is a master baker, and safe to say he has his hands in a lot of pots. So many, it nearly killed him.
Just thought it was my schedule, my workload, just my whole lifestyle.
After one too many migraines, Michael went to get an MRI, and it showed he'd had 3 strokes.
A chef from Prescott Valley is on the mend after suffering.
I guess I've taken
A new throat therapy.
And so you know how.
Chef.
I couldn't drink any liquid. I couldn't eat any food. And I was barely able to bring down my saliva that my mouth was producing.
And so you know how to swallow is in your brain. So when you have a stroke in that area, it affects your ability to swallow.
Banner University Hospital in Phoenix just started using a new throat therapy for this exact issue. A special electric catheter that stimulates the throat muscles to kind of retrain the brain. This is Michael in a therapy session.
What it does is it just kind of forces the patient to swallow.
And after a few sessions, the master baker is back in the kitchen, but now putting life's pressures on the back burner, enjoying every bite, and always full of gratitude.
I guess I've taken my taste, my swallowing, my eating for granted. I'll never do that again.
Brian Webb, Fox 10 News.
The system was developed in Europe 10 years ago, but just approved by the FDA last year, and Banner University Hospital in Phoenix is one of only 3 hospitals in the country to use it.
I'm Katie, the speech pathologist. I'm going to speak about pharyngeal electrical stimulation as well as a couple case presentations. I have no disclosures to report. Before we can talk about how pharyngeal electrical stimulation works, we need to talk about what it's targeting, which it's targeting neurogenic dysphagia. So the normal swallowing control, neurological control, begins with the sensory receptors in the oral cavity, the pharyngeal space, and the larynx. And these receptors send the sensory information about the bolus, such as texture, size, temperature, up the sensory pathway via cranial nerves to the swallow motor cortex. The swallow motor cortex processes that sensory information and sends a signal to the brainstem. And then the brainstem develops a motor plan from that sensory information to send the plan to the swallowing musculature. The swallowing musculature then can act accordingly on the bolus. So when you swallow, appropriate timing, duration, and strength of muscle relaxation and constriction for a normal swallow without aspiration or residue. Next slide. So if there's any damage that occurs at any point of this sensory motor loop, it can result in a neurogenic dysphagia or a loss of swallowing control and coordination. So you could have a central injury, which is direct injury to the brain cortex or the brain stem, which would impact the processing of the sensory information. So something such as a stroke or a TBI. A peripheral injury would be mechanical damage with desensitization of nerves, such as prolonged intubation, prolonged NPO status, which removes or reduces the nerve signals impacting the trigger of the swallow, or how to modify different bolus types. Or a patient may have both types of injury. Of course, they would have a more complex and more severe dysphagia. So what do we do for neurogenic dysphagia? Currently, our treatment is mostly symptomatic management, such as modifying boluses, not yet, such as modifying the boluses, the salads such as puree or thickening liquids. We may come up with compensatory maneuvers such as a head turn or a chin tuck, or rehabilitate this swallowing musculature through swallowing exercises. But we know the sensory input is what drives our motor output. And so this is where pharyngeal electrical stimulation comes into play. Next slide. So the mechanism of action for pharyngeal electrical stimulation is to overcome peripheral desensitization or the impairment that might be present. So there is a base station with a therapeutic catheter with electrodes. A therapeutic catheter is placed transnasally with the electrodes in the specific places of the pharynx. A low energy stimulation of 5 Hertz is then used to stimulate the pharynx via the therapeutic catheter. Now, this is not neuromuscular electrical stimulation. It's not external. We're not looking to get muscular contraction or constriction. It's not high energy, such as neuromuscular electrical stimulation. Pharyngeal electrical stimulation is only trying to stimulate sensory pathways in the motor cortex, so the energy level is low. So sensory stimulation occurs in the pharynx and sends signal to the motor cortex, and therefore the connection to the CNS is reestablished. The signal to the motor cortex then causes excitation or increased brain activity, and this is what actually drives neuroplasticity. So at this point, the neurological swallowing control has been restored. We've overridden the peripheral impairment via sensory input, and now this peripheral sensory signal can communicate back and forth to the CNS to impact motor output. So when we use the pharyngeal electrical stimulation, the sensory stimulations directly to the vagus and the glossopharyngeal nerves, impacting increased excitation to the swallowing motor cortex, increased brain activity at the swallowing motor cortex, which is then again causing restoration of the swallow control coordination or these neuroplastic changes. So this is the only therapy treating the source of the impairment for neurogenic dysphagia. The system itself, as I said, has a base station and therapeutic catheter with electrodes. Once it's placed, the speech pathologist connects the catheter to the base station, and there's a patient-specific stimulation level at the beginning of each therapy session to make sure that we are delivering the unique sensory capacity and tolerance for that patient each day. It's 1 treatment a day, 10 minutes a day, for at least 3 sessions, but up to 10. And while the catheter is therapeutic, it may be also used as a feeding tube if the patient doesn't need post-caloric placement. Once the catheter is in place, we achieve the optimal stimulation and ensure every session is tailored for that specific need. Next slide. excuse me, I think I might have misspoke. It's one therapy session a day for 10 minutes, 3 to 6 sessions. So 3 sessions minimally, up to 6 sessions, but just 10 minutes a day. So we're going to discuss 2 case studies. These are 2 patients that had significant benefits from using pharyngeal electrical stimulation. They both have complex and severe dysphagia, but great results with pharyngeal electrical stimulation. They both had strokes that caused direct damage, one to their brainstem and one to their cerebellum. So our first patient's a 58-year-old male who came to a hospital affiliated with our system, but not our main campus, on August 19th with a left dorsal lateral medullary ischemic stroke. That Wallenberg syndrome we heard Dr. Alexandro discuss earlier. These patients typically have the most severe and complex dysphagia. It is often, they do not resolve inpatient. They often get a PEG and continue to get treatment for quite some time as an outpatient. And often their most severe deficit is dysphagia. This particular gentleman could not manage his secretions. He said himself he felt that he was waterboarded when he had to go to his MRI. He couldn't lay flat comfortably, and he could not sleep in the bed. He had to sleep upright. So we don't have the direct images from the fees from the facility we're affiliated with at another campus, but we do have the report and the findings. I'll briefly go over the scales, but those are also available later in the slides. So we did his fees at that hospital 821. He was recommended MPO with ice chips and small sips of water. And on that fees, the findings, we do a Murray secretion scale. This is a 3-point scale that looks at secretions, where 3 is the worst, meaning aspiration. So as I said, he was aspirating his secretions at baseline, which he knew was actually obscuring airway visualization on our fees. His penetration aspiration scale, which is an 8-point scale that looks at the presence in the response of penetration and aspiration, showed the worst scores possible. 8 is the worst, indicating aspiration materials entered the airway and the patient was not sensate and did not clear it. The Yale pharyngeal residue scoring, which is discusses or references the presence of bolus material remaining in the pharynx after the swallow, showed that mostly his residue was judged to be moderate to severe, noting we did not test solids due to the severity of his swallow. Functional oral intake scale is a 7-point scale that looks at the consistencies the patient can have orally versus tube dependence, 1 being the worst. He scored a 2 because while he had a nasogastric tube, he was allowed to have sips and chips. The EAT-10 looks at quality of life and how it's impacted by dysphagia, with 40 being the worst score. He gave himself a score of 38 out of 40. Next slide. So again, the fees was completed at the outside hospital. We don't have the exact images, so we did find stock photos which depicted what we found on the findings. And as they was reported, you can see on the left pre-treatment secretions within the laryngeal vestibule obscuring visualization with aspiration. You can see below that the aspiration of the bolus through the posterior trachea and over the area of glottic folds. This patient did get 4 treatments of pharyngeal electrical stimulation. The anticipation was 6. He was our first patient at our facility to do it. It was very novel to us. Dysphagia was his only reason for admission. So after his 4th session, he did receive a PEG tube approximately at 2 a.m. in the morning. The next day I followed up, and he subjectively said, I can swallow my secretions. I can tell my swallows better. I could hear his vocal quality was better, and subjectively thought his secretion management might be better. So we did do the fees. So he had received 4 pharyngeal electrical stimulation treatment sessions, and his results were pretty significant and remarkable. He was able to advance to a minced moist diet with mildly thickened liquids with strategies, which is a sustainable diet. Unfortunately, he received a PEG literally hours before that diet recommendation. You can really note that he goes from gross aspiration of his secretions into his airway, and after 4 sessions, he does not even have the penetration or aspiration. And the same with the aspiration of the mildly thickened liquids, which is not noted after 4 sessions. Next slide. So we know that the pharyngeal electrical stimulation benefits are seen within 24 to 72 hours and possibly even longer. We saw the significant results in such a rapid time, and the patient was placed on a diet. Arguably a PEG avoidance, but the PEG was already in place. He went from aspirating secretions to not even penetrating secretions, nothing within his laryngeal vestibule. He went from aspirating all consistencies silently, without response, without clearance, to tolerating with boluses with improved safety and efficiency. And while he did aspirate on the repeat fees, he was sensate to it and able to achieve closure with strategies and or reflexive coughing and reswallowing. His residue scales all improved, going from grossly moderate severe to mild to moderate. And notice that he was able to have solid foods on his second exam, and he did get recommended for minced and moist solids. His FOIS is a 3 because he did have the PEG in place, and they can choose to use it for supplementation prior to discharge. However, his EAT-10, his quality of life, was grossly improved. Next slide. He was seen at our outpatient clinic roughly a week later, and we do see the benefits that are the ongoing benefits of post-pharyngeal electrical stimulation improvements. So he left our hospital on the 26th, minced moist solids with mildly thickened liquids. He was then repeated at the outpatient clinic on September 5th and was further advanced to soft and bite-sized solids, which is, for all intents and purposes, solid food that's cut in approximately 1.5-inch pieces, easier to chew, and thin liquids. So he no longer had thickened liquids, and he was bumped up on his solid foods, and reportedly, and he was very comfortable, and his quality of life significantly improved. In my clinical experience, I had never had a patient with this diagnosis, with this profound dysphagia, recover to an oral diet while in-house alone sustainable, but this guy actually shows a remarkable rapid recovery. Within approximately 2 weeks, he resumed oral food within a week of his stroke and continued to progress the following week. Next slide. Our second patient is a 25-year-old female. She was admitted with a pica CVA with cerebellar involvement. Her fees was completed the day of admission on 11/28. She couldn't clear the residue from her pharynx. She had variable aspiration events, different tolerance across consistencies with variable sensations. She also was noted to have a hypomobile right vocal fold. After her initial fees on day 1 of admission, she was recommended to have MPO. She could have occasional sips of mildly thickened liquids. You can see her scores. She was also aspirating her secretions, but not as grossly as our previous gentleman. She did not aspirate all consistencies, but due to material within the laryngeal vestibule that did not clear, as well as residue within the pharynx that did not clear and further progressed, she was not deemed safe and at high risk for postprandial aspiration. Her FOIS was a 3, as she was allowed to take the mildly thickened liquids, but she was tube dependent, and she did not complete the EAT-10. We initiated therapy on 11/30 following her stroke workup. Next slide. So she received 3 treatment sessions, and her 3rd treatment session was in the morning with her repeat fees in the afternoon. She again showed remarkable and rapid recovery. She was advanced to a soft and bite-sized diet with thin liquids. She did avoid a PEG. She had no pooling of secretions and just trace presence of secretions. And she was no longer aspirating the trace residue, or her residue, as she was before. Next slide. So again, she showed significant progress. She only completed 3 treatment sessions and had remarkable recovery. She managed her secretions, demonstrating improved airway protection. She initially had demonstrated aspiration and penetration, which were the variable sensitivities. On repeat, she did not have any penetration or aspiration, demonstrating significantly improved safety of the swallow. Her Yale pharyngeal residue severity scores also improved, which tells us she had improved swallowing efficiency. Her FOIS was a 5, but she did have to have some special preparation, as we did recommend the soft and bite-sized solids. So why am I so excited about this therapy? This is our interventions currently in acute care are very limited, and including evidence-based. So this is our first therapy that not only has 25 years plus of research behind it, so it's very evidence-based. It gives us options for early dysphagia intervention, which Dr. Alexandrov talked about how important that was. But also now I've seen the most remarkable recovery with patients rapidly getting on an oral diet, including sustainable oral diets and several PEG avoidances in my short time using it. There are no serious adverse effects that have ever been reported. It's easy and efficient, and success isn't dependent on your patient's participation. It's a passive therapy. So some of our patients that can't participate in traditional swallowing therapy now have a very excellent option that, like we said, it's evidence-based. This is the only therapy that treats neurogenic dysphagia at the source of the impairment. Our patients are avoiding PEGs. At our institution, of our 6 patients, 4 of them were potential PEG candidates. 3 of them did not get a PEG. We could say our one gentleman may not have gotten a PEG had the fees been done prior to that, or had not gotten a PEG at 2 in the morning. All of our patients have discharged on an oral diet. We had 100% improvement on the FOIs as well as the quality of life, 100% improvement on their penetration and aspiration scales, in their Yale pharyngeal residue scales, and 67% improvement with their secretion management. Most of all, my patients have all reported a significant improved quality of life, including my gentleman that I discussed earlier, who couldn't lay flat for an MRI or in bed. Within 2 treatment sessions, was able to sleep in a bed rather than a chair. Next slide. So I'd like to thank a ton of people. For the sake of time, they're all listed here, but mostly it's our clinical manager, a collaborative speech pathologist at my site, our neurology and neurosciences, and neurosurgical teams.
Hello, everyone. I'm Brenda Towsley, and I'm a clinical nurse specialist, and I am happy to be able to share our experience. I'm going to talk a little bit about how we brought this into our facility. Next slide, please. So you heard from Dr. Alexandrov that why he wanted to find a solution. Doing nothing wasn't an option, and he went looking. Things started to move very quickly. He wanted to get it in. He wanted to get this person treated, and our target date was 10 days from the time I found out about it. So next slide, please. So as you know, Banner Health is a fairly large health system. And so if we want to change something or add something, there's a process that we have to follow. This is a kind of a mock-up of our process. It's the bones of it. So initially it starts with really identifying that there's a need. And Dr. Alexandrov obviously identified that we had that need. And so then we have to create a use case for that product or that whatever it is. And so basically what the use case does is it explains to everybody what it is and why it is that we want it. And we have to do it in such a way that everybody can understand it, because not everybody who is part of that approval process are clinicians. So they don't understand how dysphagia works and how all of that affects the patients and stuff like that. So once we do that use case, then we have to present it to multiple groups across the system. And so even though this was going to be local, we would have to take it to system teams to do that. And so we have to take it to them, present that value proposition, why it's something that we should do and all that. And then once we get all of the approvals, then we can go and get the contract signed. And once we get the contract signed and everything, then we can start getting that equipment and the supplies in. So then it's working with your supply chain people, biomed, all of those people that can help you to move this process forward. And then once we do the kind of get things moving a little bit, then we have to start thinking about what is our workflow? How are we going to do this process so that everybody knows what their responsibilities are and what are the pieces that they own and how does it all work together? And so for the Phagenics catheter, we had to really do the workflow. What was speech language pathology? What was speech therapy's responsibilities? What was nursing's? What was the physician's responsibilities? Pharmacy, the dietitians, all of those people that we had to do. And then as you're working through the workflow, once you kind of get that done, then you have to look at, does our documentation support that? Does it support does the order support it? Where the nurses document support it? Where if the speech therapist document, what does it support that? And then really it's looking at some of the downstream stuff, the things that nursing and probably speech therapy and everybody doesn't really think about if we're at the bedside or in the acute care part of it, because it's how does things get billed, how does it get coded and things like that. So I've learned a lot about those things. But then you have to start, once you kind of get those things in process and you kind of know what your workflows are going to be, then it's looking at how do I educate all of the stakeholders for this. And so looking at everybody who's going to have a part of taking care of that patient with that catheter in. So your nursing staff for the placement and the management of that catheter, your providers for their documentation. They have to order it, they have to document, because it's the physician's documentation that counts as far as being able to charge for the catheter itself. Your speech language pathologist, how do they know which patients are appropriate and how do they then do the treatments once they identify those patients? And then pharmacies and the pharmacists and the dietitians have to be a part of that too, because we feed through this catheter, so we have to be able to they have to know those nuances of what that catheter is, what kinds of things work well with it, maybe what doesn't work so well with it. So all of those. And then medical imaging always for those feeding tubes that we put clear down into their stomachs, because they sometimes we can't get them to go all the way down the way that they're supposed to. And for medical imaging, the other thing that we have found is that one thing that we needed to do a better education of at the beginning was this doesn't go post pyloric. So that's part of the physician education that we planned, is it doesn't go post pyloric, but we didn't really say that to medical imaging. And so when our radiologists were reading it, though, they were trying to get us to continue to reposition it, and so things like that. So this process here probably took me about 4 months to get the Phagenics catheter approved, and so it's it's really a timing thing. So if it's not all the groups met every month, not all the groups met. If you missed one, you had to wait till the next month. So it just takes some time to get them through all of those system processes. So next slide, please. So part of our building that use case for getting the approvals and starting that, for Banner, we always start with an SBAR. And so the SBAR is really to explain what it is that we're asking for in a way that everyone can understand. So this is the one that I developed for this process. And so our situation was really that this is a new product. It was approved by the FDA, and it's another tool that we can put in the SLP's toolbox so that they can actually do so that they can treat the stroke patients with the severe dysphagia. And then for the background, it's how do we do it now? What is it that the SLPs do to treat dysphagia without the catheter? And so what they do now, and then what is the research that supports that? And then our assessment was, yes, this is a novel treatment, but it really can improve the outcomes and the quality of life of our patients. And so our recommendation was, yes, we want to trial this and we want to make it available to all of our patients. Next slide, please. So like I said, the formal process took about 4 months. Dr. Alexandrov, because it was, the hottest summer on record in Phoenix, Arizona, last summer, he wanted to treat our patient sooner rather than later. So we were on a very accelerated timeline. And the timeline was only made possible simply because I had everybody that I rallied to it, they really fell in with the process. I mean, they made it a priority, and then we were able to get things done a lot quicker than even I thought was possible. So it started with our system education team. That was who our CNO first contacted, and that's who contacted me because I'm technically part of them. Because our CNO had some questions as far as the scope of practice. She was thinking nursing for the treatments and not the SLP. So not understanding exactly what the process was and stuff like that. So that was kind of where we were. But then it was talking to our nursing leadership and the EMU RN navigator, because that's kind of where we wanted to put the patient and stuff like that. So there's a lot of people that had a hand in making this possible. And then it was our stroke navigator. Tiana was instrumental because she was that link between everything that we were doing to get things going so that we could treat this patient and the communication with that patient, so that everything kind of met in the middle when we were all ready for it all to happen. And then supply chain, getting them involved in the process. They helped a lot with the whole thing, clear from the very beginning, clear to the even now, they're still very supportive of it. And they're the ones who helped to get those contracts in place and get the equipment and get the catheter in here. And they did that in about 5 days, which is unheard of. And then Biomed, they reached, or when the base station came, Biomed had it back to me within a day. I could have actually started treatment on that patient the Friday before we actually did, because everybody jumped in and did what they were supposed to do. Cybersecurity, usually that takes like weeks to months sometimes to get cybersecurity's approval. I had they got on a Teams thing with me, and we had them right then and there. They made the decision. They said, yes, you can go ahead. We're good to go. And so we were able to continue on with our time frame that we were wanting to do. And then we had to get leadership for the SLPs as well as for nursing, because this was a very short time frame. And so we had to have nurses that were available to receive the education, and the SLPs that wanted to do the treatments and stuff like that and learn how to do the treatments. So they had to round up their staff so that when Phagenesis came on that next Monday on the 17th, that we had nurses for them to teach as well as SLPs for them to teach, so that then we could do our first treatment. So the time from when I found out about it on a Friday afternoon to the time that we did our first treatment, we had Phagenesis in Arizona on the ground doing education, doing our first treatment, was 10 days. So that adage, and Dr. Alexandrov alluded to it earlier, it does definitely take a village. It was so very true for us, and without that village, we would have gotten it. Not to say that, we just wouldn't have gotten it as quickly as we did, and we wouldn't have been able to treat this patient as quickly as we were able to. So she would have had to continue with her Jello shots for quite some time. But because we had to, go so fast to get her treated, then we had to kind of figure out some of our other processes after the fact. So, we did what we needed to do to get her up and running so that she could have the treatments and hopefully be able to improve her swallow. But, we didn't have all of the workflows figured out and the documentation figured out and all of those other pieces. So that's what we kind of did over those next 90 days, where we had to look at what is it that we need to do to make this sustainable. So next slide, please. So let's talk about that use case again. So the use case is really answering that why question. It's why does this make sense for us financially to do it? And what are the clinical benefits? How is it going to benefit the care that we provide to our patients? And I think that Katie spoke very nicely to how it benefits our patients. So that one's kind of a given. Next slide, please. So For the Phagenics catheter, the financial piece was really evaluating those margins. So how much do we make now with these patients? And then how much would we make if we added this therapy to it? Because really what we're doing is we're adding an extra cost, right? The speech language pathologists, they charge for the time that they are doing a therapy. This is just another toolbox in their toolbox. So it's not an additional charge that they make. So it's something that they can do. So that's something that we had to, kind of take into account, that it's not going to actually generate a whole lot of extra income, except that it's going to avoid some things down the line. And those are some of the things that we had to do that. And then you have to make sure that they understand what that NTAP payment is, what that means, that it really helps to offset the cost of the catheters, especially, or not especially, but for our Medicare patients. And we just did an analysis of our first 13 patients, and our financial analyst, she was very cute when she said it. She said, we are showing a trend to the positive. So we're in the green, and green is good. So that's what we cared about. And then the quality outcomes were a much easier sell, because there is a lot of research out there in Europe that says that this improves outcomes. So that was easy part. And then when I did take it through the final, or the formal review to all of the big teams and all those people, we had our own patients. We had the stories of the Michaels and stuff like that we could take to them, that we could show this is our actual experience and not just what the research shows in Europe. So, and then the research is also very supportive, or shows a lot of support for decreasing those complications that are a part of dysphagia care. So next slide, please. So some of the takeaways that I want you to have for tonight is, number one, we need a physician champion, or any kind of champion. Physicians work very well, though. They speak very loudly to administration. Having a neurologist or somebody who's very involved in your stroke care is very, very beneficial and makes a huge difference. You need to have somebody who truly believes in the efficacy of the therapy. So somebody who can articulate why our patients and how it can avoid costs, because that's a lot of what we're going to be doing, is avoiding costs. And then I think that our SLPs were also great champions for this. And then you have to really make sure that you get that buy-in from all of your stakeholders. So it's real important to have those champions, because they can help make that buy-in to those other stakeholders a lot easier. And then getting that administrative support, I think I listed the top three, is one, showing them that the therapy really does work and it helps to improve the quality of life of the patients that we're treating with it. And then I think the other two are more process items, but one is, and Katie showed you a lot of the different choices that you might have. We started with the EAT 10, but figuring out how you're going to measure that. What are you going to do pre-treatment? What are you going to do post-treatment? And how far out maybe are you going to do follow up with these patients, so that you kind of have that timeline kind of figured out and what you want to do. As Katie said, not everybody can do the EAT 10, so having a couple of different ways to measure that is always a good thing. And then making sure that you have a process in place for those NTAP payments, because that goes back to that financial piece. And so that's something that administration and everybody thinks is very important. So again, I really can't thank our whole team enough. Without all their help, without their buy-in, without their support, and they are still supporting it almost a year later. So they supported me through the accelerated timeline, through the formal process, and they're still doing it. So I can't thank them enough for all of the help that they gave me. And last but not least, next slide, please. So this is from our patients. So you can see what some of our patients have said. So patient number one is that one that Dr. Alexandrov was talking about. What she told Tiana when she did her follow-up phone call was that she was glad that she could have a beer. It wasn't the Coke she wanted, it was the beer that she had. So she was ecstatic that she could do it. Then Michael, the video that you saw, it was devastating for him, and he noticed improvement after his first treatment. And then Jeremy, who's a healthcare executive, he had been choking, literally choking. He said, I felt like I needed the Heimlich sometimes. for 6 months. And within 6 days, he felt dramatic improvement. So, and we have a whole lot more stories of this from our patients, and but that's probably for another time. So I want to thank everyone for joining us, and I think we're going to do questions now.
Okay, so Katie, you mentioned that Phagenics treatment is easy and efficient is the verbiage that you use. Can you speak more to that? Like, how much time does the therapy take? What training is involved to use this therapy?
So for the training, the wonderful clinical specialists, the SLPs from Phagenesis come on site. They go over the theory and how to use the actual device and the science behind it. That takes, I can't think, maybe, I think we got it down to 90 minutes in a pinch, but so you learn everything and do your competencies within then, and then the speech pathologist accompanies you to your first patient, so you're supported the whole time. Everybody's been on demand, on call, a text, a call away. There's never been a time that I haven't been able to get somebody pretty quickly. As far as time with the patient, I allot for 20 to 30 minutes. The direct stimulation is 10 minutes. However, when I go in the patient's room, we position the patient, oral care, ensure the catheter is in place, connect them. We're going to get their threshold or the lowest frequency they feel the stem, and then we want to get their optimal. So we have their frequency for their best stimulation for therapy. So that takes a little time. Then the direct stimulation is 10 minutes. Typically, the first 2 minutes is the most sensitive for the patient, but they get through it pretty well with coaching, or sometimes not at all. They just do. And we'll see increased in swallowing frequency. Patients are reporting improvement within a couple sessions, but the actual time with the patient typically is 20 to 30 minutes, maybe 30 the first day. And then after that, once you have things kind of set up, it takes about 20 minutes. And as we talked about, it's passive therapy. So the patient does not have to be verbal. The patient does not have to be participatory. It's delivering that electrical stimulation for the sensory pathways to the brain for the excitation and reorganization.
Brenda, can you speak to who places the catheter at your institutions, and kind of what does maybe billing documentation look like for that?
The nursing pace does it just like they do any other kind of feeding tube. Like I said, it's not post-pyloric. So what we have learned is you need to make sure that your order reflects that it's not post-pyloric, that it's only for gastric placement. There's some nuances to placing this tube versus a regular feeding tube, whether you use it. One, it doesn't do the core track. So if that's how you place your Dobhoffs or duo tubes, whatever you call them, it doesn't use the core track. So it's a blind, just like we used to do in the old days. And the nurses will place it, but because it's, I have one right over here, I was going to just grab it, but because of how it is, to make sure that you get the treatment bands where they're supposed to be, those little electrodes where they're supposed to be, and the feeding tube in the right spot, there's some nuances to it. And so the SLPs that come out from Phagenesis, they do a lot of they do the education for all of that. And then I do a lot of reinforcement with the education for all of that. So it takes some time. And there was a second part to that question, sorry.
You know what, that actually leads to a really nice question about electrode placement. So either Brenda or Katie or Dr. A, you're there too. Can you speak to how do you know that the electrodes are in like the right place?
Katie, do you want to speak to the markers that are quite easy to navigate, that you know you're in the right spot when you place it?
Would you like to?
Yeah, there we go.
Oh, look at that. Yeah, so our nursing team does place it, and so they measure from the nose down as she described and get the placement. There's black bands that'll be at the nose where the bridle is, and then in the oropharynx there are, I believe, green bands where we check. So I always check the black band first. You can check the green band as a secondary.
I think I have one question, actually, Dr. A, this will go for you, but how did you kind of convince other physicians or your ICU team to kind of buy into this treatment?
Well, I didn't convince anyone. I acted unilaterally. Patient did a treatment. I said, I did it. I need it done. And I called CEO literally and asked.
You did.
Yeah. So, and when I was a junior, I was doing the same thing. If I saw a problem and I was the only one at bedside, I would try to fix it. That's how I was brought up.